Good evening, and thank you for joining us. My name is Kevin Bergerson, and I'm the program's assistant manager here at the Colon Cancer Alliance. And on behalf of the patient navigators and the entire patient support team from the Colon Cancer Alliance, I would like to welcome you to the latest in CRC findings from the 2016 ASCO GI Cancers Symposium webinar. This is the 16th installment of the Conversations About Colon Cancer webinar series, which the Colon Cancer Alliance created to provide you with the latest trending information on colorectal cancer issues and trends you need to know. Tonight, we'll be reviewing many exciting outcomes from the ASCO GI meeting last month. It is important to note that neither the Colon Cancer Alliance nor Dr. Laura Porter are giving medical advice, and no doctor-patient relationship is intended or established. You should always seek in-person medical advice and make medical decisions together with your individual clinician team. It is my pleasure this evening to introduce Dr. Laura Porter, medical advisor and senior patient advocate with the Colon Cancer Alliance, who will be walking us through the ASCO GI findings. Dr. Laura is uniquely positioned to serve as our medical advisor. In 2003, Dr. Laura Porter was in her second year of her pediatric residency when she was diagnosed with stage 4 colon cancer. In May 2006, she became cancer-free after many medical interventions. Dr. Laura's medical background, battle with cancer, humor, and honesty uniquely positioned her to technically and passionately share her message of hope and survival with our community. And with that, Dr. Laura, I'm going to turn the presentation over to you. Welcome, Dr. Laura.
Thank you, Kevin. Let me, all right. Are we there?
You're up.
Okay, excellent. I'd like to welcome everybody this evening, and thank you for, it really is a privilege to present this information. And thank you for the wonderful introduction. So we're going to start with some of the highlights, and then I'll go into the details. So first I want to cover the worldwide statistics, current screening options, update on rectal cancer, update on metastatic colorectal cancer, what's on the horizon, in the pipeline, and the confirmation of previous findings. So first I have some maps from ASCO GI that were presented. Normally I don't go into world statistics, but I think these are kind of important. The darker the blue, the higher the incidence of colorectal cancer is. So there is a rising burden in Asia, Canada, and Europe. 50% of the countries that are impacted have high income. They call it a disease of affluence because of a sedentary lifestyle, high-fat diet, and the highest, but the highest incidence is in high-income countries, but also the higher-income countries have the most treatment options, and that'll be, you'll see that on the next slide. So this is the cancer mortality, and you can see that the United States and Canada have, a fairly high mortality. But if you look at Russia, Russia is the worst, and part of the reason for that is they have no screening program. So now I want to talk about the progress in the United States. So overall, the incidence in the United States is declining, and this is due to screening. And when I say screening, I'm talking about average risk individuals 50 years to 75 years old. So currently, I want to discuss some of the current tests that we have available. There are 3 annual at-home tests. I'll go into a little detail in a minute, but the first one is fecal immunohistochemical test, or FIT. The second one is guaiac FOBT, fecal occult blood test, and then the third one is a newer one, and it's Cologuard, and it's a stool DNA test. So the results of clinical trials have been that FIT is more sensitive than FOBT and has reduced mortality from colon cancer. The early results show that Cologuard used in conjunction with FIT is superior to FIT alone. So again, these tests are only for average risk individuals. They do not apply to us. Us who have had a history of colon cancer or first-degree relatives that are at an increased risk. The message here is to get the word out to your friends and family members that aren't first-degree relatives to be screened, and that there are options. If they don't want to do a colonoscopy, there are other options. So more sensitive tests appear to be coming, including blood tests. So as I said, colonoscopy remains the preferred screening method. The reasons for this is that it's a single test performed every 10 years, depending on your risk, and the polyps that are detected can be removed during the procedure. But that being said, the best test is the one that someone will do. And globally, people are doing the annual FIT test. In Europe, that's what is done for screening. They don't generally do colonoscopies. They do FIT tests. So here's a picture, the FOBT, which has pretty much been screened out. You have to have 3 separate stool specimens. And the trick about this one is that I used to do this all the time. I used to develop it. You put a little chemical on it, and then if it turns blue, there's blood. But it's up to you whether you think it looks blue or not. So it's very open to interpretation. And the FIT test, on the other hand, the results are run through a computer, so they are more reliable. And it only requires one sample. And the FOBT, let me go back to the FOBT again, I forgot to make this point here, is that there are dietary restrictions with the FOBT because it detects blood, and it doesn't detect human blood, it detects all blood, so which is a problem. So with the Cologuard, this is the newest stool test, the DNA stool test. It is also one sample, and it is also quantitative. That means that it's run through a computer and not just somebody's eyes. Believe me, that's important. So the incidence in colorectal cancer in the United States is declining. So the first line, the blue line, is the overall incidence, and that's declining at a rate of 3.4% per year. And the incidence in those over 50 is declining by 3.9% a year. And the reason that the graph is not, the lines are not superimposed is because the incidence is increasing in under 50 by 1.1% per year, which is a huge increase. This is something that is very, well, I mean, I was diagnosed at 43, and I'm sure many of you were diagnosed under 50, and it is a critical issue that has been around for a long time that is finally getting noticed, thank goodness. So I want to talk about a couple of different procedures. This is the flexible sigmoidoscopy. Personally, and this is my personal opinion, I don't think they should be done. The recommendation is every 5 years, but as you can see, they do not get to the end of the colon. This is as far as they go, is to the sigmoid colon. And they don't reach the right side. So a colonoscopy, on the other hand, does reach the right side. But the information that came out at ASCO this year was that, ASCO GI, was that It does reach the right side, but it does not decrease the deaths from right-sided colon cancer. So it detects the cancer, but it doesn't decrease the deaths. So, and they're not sure if that is due to the biology of the tumors, whether it's because of the kind of polyps that develop on the right side, or if it is because of the quality of the colonoscopy. And I'll be discussing the quality of the colonoscopy on the next slide. So the steps for an effective colonoscopy, the very first thing is an excellent bowel prep. And this you have control over. It's very important to have the bowel clean. I've got some pictures of colonoscopies coming up, and you'll see why it would be important to be able to have it as clean as possible. You also want a well-trained and meticulous colonoscopist. And I'm going to go back here and show you that this part right here is where the large intestine goes into the small intestines, and it is called the ileocecal valve. That's not important, but what's important is that the scope needs to go all the way through that, through the valve into the small intestines, in order for the colonoscopy to be considered a complete colonoscopy. So complete removal of adenomas or polyps. Whatever is seen needs to be removed, and the importance is being able to see it. And reaching the right side of the colon, like I just talked about, and then appropriate withdrawal time. The reason that the withdrawal time is important is because that's when the doctor actually visualizes the colon, when they're withdrawing the scope, not when they're inserting it. So that's very important. So what questions can you ask your doctor? What do you need to ask your doctor? You need to ask them, how are you measuring and reporting a successful colonoscopy? Did you get to the right side? Were there any polyps? Did you remove them? How was my bowel prep? These are the type of questions to ask. So, some colon polyps. These are called pedunculated polyps. That's not real important. What's important is that they're on a stalk, a stem, and they're easier to see. So they go in, they put a little loop around it, they cut it off and remove it. This is a sessile polyp. So it's not on a stalk, but it's raised enough that you can see it. And you can see why it's important to have an excellent bowel prep. Very clear to see those. These are flat lesions. And this is white light, not dyed. You'll see some that are dyed here. But you can see that they're slightly raised, but they're considered flat. These are the lesions that are usually missed in a CTC, which is the computed colonography. A serrated lesion, not the greatest picture, but and then flat serrated lesions. These are the one on the left is white light. The one on the right is stained, and you can see where there's some discoloration in here, which is where the lesion is. But you can see how difficult that is to see it. Then we have the conventional flat adenomas, which are very difficult to see, and then a depressed adenoma, which is underneath, and this is these are the folds of the colon. So now I want to talk about the standard of care revolution in rectal cancer. The status quo has been for the last 10 years or so that people receive chemoradiation, surgery, and then more chemotherapy. So chemoradiation, just so that we're on the same page, is usually 5-FU or capecitabine given at the same time as radiation therapy. So what they're finding now is that surgery may not always be necessary. So people could possibly avoid surgery after chemoradiation if the tumor has shrunk enough. Also, chemotherapy may not always be necessary if chemoradiation and/or surgery were successful. And radiation may not always be necessary. And there are clinical trials looking at the different modalities. So, so there's no cut and paste. It's individual. So, in one of the most exciting studies that was presented was a Dutch study that showed that short course radiotherapy and chemotherapy was as effective as long course chemoradiation. So the way they do the radiotherapy and chemotherapy is alternating, and it's a lot less time than 5 weeks, which is normal for chemoradiation. So you would get chemotherapy and then you would get radiation therapy, but not at the same time. So they found that this reduced the side effects from chemoradiation, and it looks very promising, and everybody was very excited about this at ASCO GI. But before it's accepted practice, there needs to be longer patient follow-up, but the early results look good. So, and the other thing is rectal cancer staging should be done with an MRI, not ultrasound. Usually they do an ultrasound to assess the lymph nodes, but what they're finding is that what's more important is the vascular invasion. Vascular invasion is the tumor invading the veins or the arteries, which causes the metastases. So also with an MRI, metastases will be able to be seen. And as always, the pathologist needs to measure the depth of spread. Has it gone through the wall of the rectum into the surrounding tissues for staging of the disease? So now I'm going to switch to metastatic colon cancer, colorectal cancer. So I just want to say that this is a very busy slide, and I don't expect anybody to remember this, but 12 years ago, when I was diagnosed, there was 5-FU and irinotecan. That was it. Oxaliplatin had just been approved. So these are all these drugs you see, except for the 5-FU and the oxaliplatin and the irinotecan, are new in the last 12 years. And there have been incremental gains, but they've been impressive. And I think that's important to remember. I remember when I was put on Avastin, and I read the report, and it said that it extends life an average of 2 months. And I was like, 2 months? That's nothing, you know. But obviously for me it did more than that. But what I realized is that if you're on one for 2 months, another for 2 months, another one, you know, and if you respond more than the 2 months, then it's an advantage. So there's been incremental gains, but the overall survival's gone from 6 months with best supportive care to around 30 months. And that's just average. That's not, you know, special for you, because mine is definitely the exception to the rule, too. So some other news with metastatic colorectal cancer is everybody wants to know, should we get on the FOLFOX or the FOLFIRI first? So the study came out and it said that FOLFOX plus Avastin or bevacizumab is equivalent to the FOLFIRI plus bevacizumab. So basically what that means is you can either go on the FOLFOX bevacizumab first or the FOLFIRI bevacizumab first. And then once you progress, if you do progress, then you go on the other one. So they're pretty much interchangeable. And this is good news, that it gives people options. Another thing that came out is FOLFOXIRI. So FOLFOXIRI is 5-FU leucovorin, oxaliplatin, and irinotecan, all given at the same time, plus the bevacizumab. And they found that this can be used as a first-line treatment, and that in some cases, progression-free survival and overall survival have increased. So, and that's really good that there's these options. So then there's TAS-102 and regorafenib, and they found that those two are equivalent. Regorafenib and TAS-102 are equivalent. Either one can be used as third or fourth line therapy. Another item is for metastatic CRC. So ovarian metastases are present in 5 to 10% of female patients. These metastases must be surgically removed because the ovaries are protected from drugs. They're kind of like little islands. So let's see what's on the horizon. So laparoscopic surgery in rectal cancer, there are differing opinions about that. And so the good thing about the laparoscopic is that it is less invasive and there's a quicker recovery. But the question is whether or not the results are as good as in the open surgery. So, and further trials are needed before there's a change. There are also new trials looking at radiosensitizers, and these are basically drugs that are given before radiation, and let's see, they reduce the amount of radiation by increasing the tumor's response to the radiation. Many of the drugs that are being looked at are already FDA approved, so the timing to the clinic would not be that long. So there are new markers for recurrence, but they're not quite ready for clinical use. Some involve panels of biomarkers, including CEA. There's also the liquid biopsy, which is blood, that may be able to detect recurrence. There's also a response to treatment, which can be measured with a circulating tumor DNA. Tumors put out different DNA than your regular cells, and they're able to look at these in the blood. Another thing is that 30% of mutations in hereditary colorectal cancer are unknown, and this is Lynch syndrome in particular.
So basically, what this graph shows is that for all of colorectal cancer, this amount are sporadic. So these amount of cases are sporadic, means that there's no family or genetic link. 30% of that is unknown, and this is the little piece of HNPCC, also called Lynch syndrome. So when you take this piece out and you go over here, what you have is the known mutations in Lynch, which are these 4, and then you have 30% which are unknown. So what they're doing is they're really looking into Lynch syndrome. And if you don't have the mutations, that doesn't mean that your colon cancer isn't, genetically driven. So here we go. All right. So in the pipeline, this is kind of exciting because there's a drug, it's called Nexiri. Actually, it's a regimen, sort of like FOLFOX or FOLFIRI, But what it is it's sorafenib, which is used to treat hepatocellular carcinoma and irinotecan. And what they found is that it's effective in heavily pretreated metastatic colorectal cancer patients with a KRAS mutation. And this is different than like the panitumumab and the Erbitux, which are for KRAS wild-type patients. And it adds another drug for metastatic CRC. And heavily pretreated patients are those that have been through first line, second line, third line, fourth line, which is important. And the other thing is that clinical trials used to exclude patients who had been treated with more than 1 or 2 lines of therapy, and they're not doing that anymore. So I think in the last maybe 3 years, 3 or 4 years is when they've really focused on metastatic colorectal cancer because they knew that some people could be cured. So another drug that they're looking at is pertuzumab, which is used in breast cancer, and it's effective in breast cancer, but they're finding that it's also effective in metastatic colorectal cancer who have a specific biomarker called HER2. So basically what HER2 does is it initiates cell growth and prevents the death of tumor cells. And it is more prevalent in colon cancer than it is in breast cancer. So this is another new drug that they're looking at. So some new guidelines that have just come out. So all patients diagnosed under the age of 70 need to be tested for Lynch syndrome. So basically that's a twofold test. The first test is it's called immunohistochemistry. It's a test that's done on the tumor. The second test confirms that with a blood test. So for microsatellite instability or mismatch repair. So basically what that means is that the DNA does not repair itself. I mean, our DNA gets assaulted all the time, environmental, all different types of things. So, but with the mismatch repair, then you can't repair your DNA. And this is what they believe leads to the Lynch syndrome. Also, all patients, especially those with metastatic colorectal cancer, but I think all patients should be tested for the complete RAS panel. So it used to be that they would check for 1 RAS mutation, but now they're finding that there's at least 3 different RAS mutations, and more are coming. So, and the other thing that's important here is that each new tumor or metastasis needs to be tested. So let's say you get a new met in your lung and the doctor says, listen, I need to test this. They need to test it because most likely it is different than the original tumor. And I'll show you real quickly. So here's the tumor cell, and then these are the different clones of it. So let's say it goes to the liver. This clone This clone goes to this part of the liver, and this one goes to the other part of the liver. So they could be 2 different tumors having 2 different mutations. So that's why it's important that everything be tested. So some confirmations of previous findings, and this might be a little confusing. I'm going to try to do it a little slowly here, but aspirin is effective in primary prevention of colorectal cancer. Primary prevention is in people that haven't had it before. But if you've had it, aspirin is only, if you've had colorectal cancer, aspirin is only effective after diagnosis at what's called secondary prevention in a small subset of patients with a particular gene mutation called PIK3CA. So that is only present in 15 to 30% of CRC patients. The important thing here is that aspirin is not just a benign drug. So before you start taking it, if you've been diagnosed and you think you want to try to, put off a recurrence, check with your doctor. Don't just start taking aspirin. And this is the graph that they showed. And this is in people that have the mutation who've already had colorectal cancer. So without aspirin, they have a higher probability of death than with aspirin. If they have, as far as recurrence is concerned. So the last thing I want to talk about is multidisciplinary team or tumor board. A multidisciplinary group of doctors, radiation oncologists, medical oncologists, surgeons, social workers, a bunch of different people are involved in making a decision about the most appropriate treatment. It produces a greater accuracy of diagnosis and staging. Treatments by a selected group of experts instead of one doctor, and better coordination and continuity of care. Also, treatment aligns with national guidelines, and there's a greater consideration of patient needs. This can include geriatric care, palliative care. They could bring in a social worker. Most of the large university hospitals have multidisciplinary tumor boards. Another thing that came out is that DPD deficiency, dihydropyrimidine dehydrogenase deficiency, is a rare but serious disorder. It affects 2 to 8% of the population. It can go unnoticed until the person is given 5-FU or capecitabine, and it can result in death. So signs of DPD deficiency include the normal side effects you get from 5-FU, but to a larger, more debilitating degree. Mouth sores, diarrhea, vomiting, and you know, if you have these severe side effects, it is important to call your doctor. And if you have a mild case of DPD deficiency, usually you can continue on the 5-FU or the capecitabine with a reduced dose, and that's important. Because of this, in December of 2015, the FDA approved VistaGuard, which is used for the emergency treatment of adults and children who receive an overdose of 5-FU or capecitabine, or who develop certain severe or life-threatening toxicities. So it is a real issue that's being addressed, and the fact that they have a medication is very good. So I want to thank everybody and for your patience, and sorry about the technical difficulties on my end, and I'll turn it back over to Kevin. Thank you.
All right, thanks, Dr. Laura. We're going to take it back over here, and we're going to go ahead and get started with some questions here. That was really incredible. There's such a wealth of information that always comes out of the ASCO findings that we look forward to that conference every year because those strides are so important to patients everywhere. As a reminder, if you have any questions you'd like to ask, just use the questions chat box on your control panel on the screen in front of you there. And we're going to try to start with some questions here. Early on in the presentation, Dr. Laura, you mentioned blood test. Is that going to be some manner of simple cancer protein blood test?
Yes, that's what it was. That's what it appears to be to me. I think that they're looking at a number of different markers. Right now, there's CEA, and I think everybody's pretty much familiar with CEA. But yeah, they're looking at a panel to identify a recurrence, and hopefully it'll identify it quicker, especially in those that CEA is not a marker for. So. Okay.
Very good. We have another question that come in from Mary, and she's a long-term colon cancer patient diagnosed back in 2011 with a colostomy and a urostomy, and she's tried immunotherapy trial which apparently didn't work. So she is now on Vectibux, and after being on a combination of irinotecan and Vectibux. Are you aware of any other options that may be available for her to ask her clinician team?
Yes, the two that I mentioned about the let me see, can we go back? The two that I mentioned, the one with the sorafenib and the irinotecan, I think if she calls the patient support, maybe they'll be able to, I'll try to get the information up where they're doing the clinical trials. The sorafenib and the irinotecan, and then the other one is the pertuzumab, which is an immunotherapy, which is extremely successful in breast cancer. So those are the big ones on the horizon. I don't know about whether or not she's been on the regorafenib or the TAS-102. Those are not in clinical trials anymore. They're available right now for use. So. Are you there, Kevin?
Yes, Dr. Laura. In
okay.
an earlier slide, there was reference of Tegufar and MMC, which were listed in the chemotherapy drugs. Can you briefly describe or tell us what those are?
Yeah, I tried to I looked them up based on my slide, and they are not in clinical trials right now. So they're not being used for colorectal cancer at this time. So.
All righty, and I have another question that come in here from Cassandra. Is there any new treatments for stage 4 colorectal cancer patient that has metastasized to her liver? Any innovations for her suggestions?
Well, I think on our website we have a pretty in-depth explanation of all of the different interventions that are available for people with liver metastases. There's chemo, there's directed therapies like the Certex, the Certspheres, the hepatic arterial, HAI infusion. Sorry, that's where they put a pump in and it goes directly to the liver. So RFA, where they burn out the little tumors that they can't surgically remove. So nothing that I saw that was any different than what they've been doing. So I think most of the for stage 4 or metastatic, most of the news was for chemotherapy and biological agents, not necessarily other interventions.
Interesting. Was any of those biologics happen to include any discussions on vaccines and immunotherapy trials, anything along those lines?
Yeah, the only immunotherapy trial is the pertuzumab that I heard about. And that's not saying that there aren't others going on, but that's what was presented. And hopefully, in May we're going to be going to the big ASCO, so they should have some updates on the research that was presented last month, and also some newer information too.
Offhand, Dr. Laura, Kim would like to know if you offhand know of any, what the success of SBRT on love mets is.
Oh, you know what? I do not know that. Let me make a note for myself here.
We'll follow up with you, Kim, after the fact on that.
Yeah.
And we'll follow up on a one-on-one with you there.
Okay.
And The Kim also would very much like to know, what do you attribute to your long survival of stage 4 colon cancer?
Yes, boy, I really wish I could say, well, I ate X, Y, and Z, and that's what did it. But you know, I didn't. I think that my tumors were pretty aggressive. I mean, I had them in I had 2 recurrences. The first was my ovary and my liver, and the second one was my pancreas and all my abdominal lymph nodes. And as aggressive as my disease was, it was also responsive to chemotherapy. And I'm incredibly grateful for that. And the last thing I was on was capecitabine and Avastin. And you know, I'm just incredibly grateful. And believe me, it's not lost on me that you know, that I'm an exception. And so, yeah. But I tell people, they say, well, what do you eat and what do you do? And I say, you know, it's good to take care of yourself, but you don't want to be stressed out because you're trying not to eat this or that, especially when you're on treatment and you know, it's difficult to eat anyways. So do what is comfortable for you, and I think that that's important.
Thank you, Dr. Laura, for sharing with that. I mean, it's always important for other survivors to hear the keys and what successes you've had and other survivors have had. So thank you for sharing in that regard. I've got a couple questions from Paul. You mentioned that TAS-102 is equivalent to regorafenib.
Yes.
Are the side effects equivalent as well?
You know what? That's what I forgot to mention. Thank you. Because, no, these side effects are not equivalent. And when making I think this was right before my battery was dying, so I was kind of a little preoccupied. But so the TAS-102 and the regorafenib are pretty much equivalent. It doesn't matter which one is given 3rd line and which one is given 4th line. The regorafenib has severe hand and foot syndrome in some patients. So if somebody develops hand and foot syndrome and it's really bad, then they should be switched to TAS-102. So, and I'll be honest with you, I'm not sure what the side effects are. Jeannie might know, and we can get back to the side effects of the TAS-102. But from what I understand, I think it's less severe than the regorafenib with the hand and foot syndrome. And hand and foot syndrome is basically, you know, burning and developing blisters. And I had that with capecitabine, and I couldn't wear shoes for 6 months. So, you know, sometimes it can be pretty bad. You know?
And Paul had a follow-up question then. Can radiosensitizers be used with SBRT for the lung mets?
Wow, that's a really good question. I'm going to have to look up SBRT and lung mets.
All right.
So, yeah, let me see. Radiosensitizers.
All right, Paul. Paul,
yeah.
We'll get back with you by email on that one. And Christina would like to know. She's read that researchers believe the increase in obesity may, you know, be part of the reason for an increase in colorectal cancer in young adults. Many young adults she knows with colon cancer are not overweight.
Mm-hmm.
Are there any theories as to what may be causing the increase in the under 50 crowd?
Yeah, I mean, they're really looking at it. I mean, it's kind of, I don't know. The thing is that it's mostly increase in rectal cancer too. So it's not, you know, it's not right-sided colon cancer. It's rectal cancer where there's a big increase. And you know, they could say, yeah, eat a good diet and do all of that, but I know that that plenty of healthy and people that are in shape have been diagnosed too. So, it's just going to take I think it could probably be a genetic thing, whether it's environmental or something else, I don't know. But I think it's going to be found out in the genes. So.
Mm-hmm. Yeah, we'll just have to wait to see on that as we get more and more in tune with genetics and tumor testing and what's going on at some of the DNA level. We're going to have to wait to see what happens in that arena. Candy would like to know what dosage of ASA might be indicated in the studies for primary prevention.
Yeah, that I don't feel comfortable talking about that because I don't know what, how much aspirin they were talking about. So, but I think that there's a lot of papers out there, but I would definitely talk to your doctor about that. And it is, like you said, primary prevention. So, if you've not had colon cancer before.
And we've had a question that come in about, where are all these trials being done? And we do have a clinical trial section on our website that folks might can look at where they can find clinical trials and participate and where they're being offered. So we do have that resource on our website. And we also are just about out of time. I'm going through the list of questions right now, and we've answered pretty much just about every one that we could. We do have a number that we will be following up with. So I'd like to thank you all for your questions this evening. They were very value added, and we do appreciate them. And again, we will be following up with those that we were unable to answer by email in the next day or so. We're just about out of time. So I would like to remind everybody tomorrow you'll get an automatic email from me that will be asking you to fill out a survey on how we did. We're very interested in your feedback. I promise it won't take but more than a minute or two of your time, but I'd be very interested in your feedback. We're always interested in making our webinars better every time. So thank you in advance for your input. As a reminder, if you have any personal questions you may want to ask in a one-on-one setting, there's a variety of mechanisms here with the Colon Cancer Alliance to help you with that. If you'd like to speak directly with one of our patient navigators, or if you have any other colorectal cancer questions, please feel free to contact our trained navigator team on our helpline at 877-422-2030, or visit them online for a live chat at ccalliance.org. Jeannie Moore, our patient navigator, is also available on Facebook in the Blue Hope Nation, and you could reach out to her as well. And she's always on Facebook and in a capacity there, and stands ready to help you as well. Thank you for attending this evening. We certainly hope you enjoyed this webinar. As a reminder, the webinar is being recorded and will be available for reviewing on our website in the near future. If you would like to be contacted by a particular program, please forward your question or comments to me at kbergerson@ccalliance.org. And on behalf of the entire colon cancer team, I'd like to thank everyone for attending this webinar. I'd like to thank Dr. Laura for presenting this evening. Dr. Laura, any parting thoughts before we leave tonight?
Gosh, I just want to thank you for the opportunity, and I'm just so incredibly grateful that I can share hope with everyone. And I think that that's what's real important, is the hope. So thank you.
You're very welcome, Dr. Laura. It's always a pleasure to hear from you, and we value your expertise, and we look to you as a great source of hope and inspiration for all our survivor and patient community out there. And with that, Have a good
Kevin.
evening, and take care, everyone.